Now, our next speaker. The initial burden of disease study for South Africa focused on the year 2000, and it revealed a unique quadruple burden of disease for the country, including HIV/AIDS and TB, NCDs, poverty-related conditions, nutrition, and lastly, injuries. Is this any different 22 years later, we ask? Well, Joint CEO of Insight Actuaries and Consultants, Barry Childs, looks at the burden of disease in South Africa. Mr. Childs is a member of the Actuarial Society of South Africa and is part of its National Health Insurance and COVID-19 subcommittee. In 2021, he received ASA's Presidential Award at its annual convention for service to the profession. He was also recognized for fostering a greater understanding of the COVID-19 pandemic, as well as leading the ASA Coronavirus Working Group and providing technical and analytical support for the vaccine rollout program across South Africa. His COVID-19 work has supported B4SA's efforts in pandemic monitoring and the vaccine rollout. Ladies and gentlemen, please welcome Mr. Barry Childs.
Ahmed, thank you to you for allowing the space and time for me to speak about this and the opportunity to present. Leanne, thank you for the kind introduction. So I'm going to be speaking to you today about South Africa's burden of disease. COVID, as you've heard this morning, has really been a stress test for our healthcare system, a stress test for our economy. We've come through with many scars, with great cost of life, and hopefully many lessons learned. But we have a long way to go. And some of the statistics that I'm going to show to you today actually show that going forward, given the prognosis of hopefully milder strains of COVID going forward, we actually have much bigger problems on our hands looking forward than COVID. So a burden of disease is an extraordinarily wide topic. It would be impossible to cover in detail in 25 or 30 minutes. I'm going to sort of jump around with some of the key topics, some of the key findings, and then give you a sense of what the drivers of those problems are, driving our burden of disease, and then spend a little bit of time making some suggested remedies in a few of the areas that we're going to touch on today. Our saving grace from a burden of disease point of view currently is South Africa's relatively young age profile by world standards. We have a much younger age profile, as you can see there, Africa in general, but South Africa in particular, a much younger age profile than many developed economies. We have very different problems, for example, than Japan, where the average age is much, much higher than South Africa. They have to have way more hospital beds. They have a completely different burden of disease to what we have here. As Dr. Samu mentioned, we haven't, unfortunately, been able to make good on our demographic dividend, which is something I'll speak about a little bit later. But so far, keeping our population young as it is, growing as it is, at least saves us from some burden of disease. Unfortunately, the picture is not so for a non-communicable disease. So we can see here, for example, how much South Africa stands out just from a diabetes prevalence point of view, which is the sort of poster child for non-communicable disease, really standing out like a sore red thumb at the bottom of Africa there. And this is the manifestation now of decades of problems with nutrition, of lack of exercise, lack of awareness that diabetes, heart disease, and other non-communicable disease actually creep up on you as an individual and as a country. It's not that you notice, every day the few extra grams on the scale or the changing of the belt buckle or those kind of things, but these cumulative effects over the long term of poor nutrition, lack of exercise, and other drivers of non-communicable disease really catch up with you. And so this is really a wave of cost and disease that South Africa is going to go through. And we are going to have to apply our minds to how best to remedy that. Unfortunately, we're not off of the hook for communicable disease either. You can see in the SADC region just how much of the global HIV and TB burden of disease is borne in the SADC area, particularly South Africa. We have, by some measure, the highest HIV proportion in the world for a large country. And I'll talk a little bit about the effect that has had on some sort of macro metrics for South Africa. But most developed economies have solved this communicable disease problem through a variety of interventions. Unfortunately, in our case, we're now stuck with a heavy burden of disease, both on the communicable side and on the non-communicable side. And that's why we use language like a quadruple burden of disease. So we really, really do have a very big hill to climb in terms of our overall burden. And then one of the markers, one of the input factors, the drivers of non-communicable disease particularly, is obesity. This is one of the graphs I would have loved to actually draw over time, but South Africa has been climbing up the ranks in the obesity rankings, and by latest score, we're up in the mid to high 20s now of adults that are regarded as obese in terms of the clinical definition. Now, this is a real problem. Nothing in a healthcare system is improved when you're overweight. And when we're talking about remedies for burden of disease, they are going to have to touch on things much more broad than just what's in the healthcare system, as Dr. Samu hinted at earlier. So I want to tell you a story with data. It's one of the things I like to do as an actuary. It's not an unfamiliar story to you, but I want to use it to make a particular point. So when we're looking at sort of the big picture, looking at the top down, we would think about life expectancy as a measure of how well a healthcare system is doing, how well a country is doing. Wealthier countries that have really solid healthcare systems tend to have higher life expectancy. You could pick your metric. It could be maternal mortality, it could be under 5 mortality, etc. The graphs will all look the same. Generally speaking, we can see countries that spend more on healthcare, that have higher GDP, tend to have a better life expectancy. And so I'm using that metric to tell a particular story. So the little red dot there to follow is South Africa, and all other large countries with economies above a certain size are plotted over time. So South Africa making its way up the curve of life expectancy from mid-50s to mid-60s. It's not a race, but it's fun to watch how South Africa was progressing like many other countries. And then, unfortunately, HIV began to take its hold in South Africa. And a combination of rampant HIV in South Africa, coupled with, I'm sure you'll all remember, so-called HIV denialism at the time, really shaved off 10 years of progress in life expectancy in South Africa until we managed to get our act together from a policy point of view, managed to roll out the largest ARV program in the world, which is not really a prize you want to have to win, but nonetheless we claimed that accolade. And so this is where we are now, climbing back up to where we were more than 20 years ago from a life expectancy point of view. The 2 points I want to make here are, firstly, that policy makes a difference. If you implement the wrong policies at the wrong time, it is going to have a catastrophic effect on your population. That's particularly true of healthcare. We've seen it. Hong Kong was mentioned earlier from a COVID point of view. They really had a very poor strategy to manage, particularly at this late stage. Early on it seemed to work, but now it's caught up with them because of low vaccination rates. In South Africa's case, it was HIV and TB, where we really had a very poor policy for a long time. And then the other point I want to make is that once you have the right policy, you need implementation to effect that policy. Policy is like a strategy plan. It's just what you want to do, where you want to aim. And a business with a strategy plan without implementation is really just a good idea. It doesn't really go anywhere. So what you need is both. You need a good policy and you need good implementation. And we can see that only over the last 10 to 15 years we've managed to pick up that life expectancy back up to where it should have been. We've essentially shaved 10 years off of South Africa's development, both economic and from a healthy life expectancy point of view because of poor HIV policy. Even now, we still sit within the mid to high 20s HIV positive population in South Africa. Just think about that. A quarter of our population, roughly speaking, is HIV positive. Now, ARV medicines being what they are means that people that are HIV positive can live pretty much normal, healthy life expectancy if they, maintain healthy lifestyles and maintain their compliance. But still, we now have this burden of disease baked into the health system, and we've just learned to live with it, which again is really a failure of policy at the time. We spend circa 25, probably 30, close to 30 billion rand if we take into account some donor funding on HIV and TB in South Africa, which we could well be spending on other things, including preventative care and dealing with our non-communicable disease problem. it still takes, HIV still shaves about 5 years off of our overall South African life expectancy. So if we could get it down to the level seen in other developed countries, we would have a life expectancy of close to 70 by now, and unfortunately we're not there yet. Looking within the private sector, different burden of disease altogether. We have, it's a different system. Generally speaking, private sector, and by that I mean those that belong to medical schemes, are in the upper income segments of South Africa. Medical schemes tend to favor curative care because of the P&B regulations, which I'll touch on a little bit later. There's a very wide range of richness of benefits offered, and so the burden of disease measured here on this graph by cost is very different. So we see amongst the top, airway disease, upper and lower, arterial vessel disease, which is where hypertension would sit, the most prevalent chronic condition amongst medical schemes, and other musculoskeletal, endocrine spend, etc. There's many areas of private sector expenditure where, compared to what happens in the public sector, it's almost like a luxury good. There are no real material waiting times. If you need a hip replacement or a knee replacement or a ACL repair on your knee ligament, you can make an appointment, and within days or weeks, you can most likely get that attended to, which is not the case in the public sector. And so a very different kind of resource limitation. Now, over time, if we plot this, we use this from the Insight data over a multi-year period, data representing about half of the medical aid industry that we use for our work. You can see there the last year or two viral infections in which category COVID is represented, just dramatically outpaced expenditure on other items. Here I'm just showing the top 20 using some software that we have that groups all claims into meaningful categories. So over the last 2 years, but also the private sector pretty much been overwhelmed by COVID, partly because other areas of expenditure went down, particularly elective surgery, and we don't expect to see that trend going forward. Viral infections will go back down to their normal place in the continuum, and there'll be some catch-up. We don't think that there'll be a catch-up of all of the missed surgeries, all of the missed medical cases, and so it's an interesting open question that was asked earlier about what medical schemes will exactly be doing with the surpluses they've gained over the years. I'm going to touch on a couple of causes of why we haven't been able to effectively deal with these problems, and then I'll hopefully have some time to spend a few minutes on some solutions. So firstly, it's a macroeconomic problem. Health systems operate within an overall macroeconomic environment. Over the past 20 years, our GDP has only grown by 2.1%, far below other developing nations. We have an extraordinary unemployment problem. It really is very difficult to sort of get to grips with it. We have over 50% unemployed using the broad definition. That means those that are seeking work and what they call disillusioned job seekers. So that's that group combined, out of the potential workforce in working age, 50% are unemployed. It's higher than that in the youth, in the 60%. Now you have to think about that from a macroeconomic point of view. How could we possibly plan a healthy future for South Africa if we have the wave of adults coming through into our system now are 60-something% unemployed? And then what I always useful to remind people about when talking about the macroeconomics in South Africa is the level of inequality that exists at a systemic level, of which the health system is just one mirror put up to the overall economy. 55% of our population, 55% live below the upper bound poverty line, which is 1,300 Rand a month in 2020 terms. Now, it's always nice to have those numbers in your head. It's just, for people that aren't familiar with what it would cost to be able to sustain, to live, to buy healthy food, to buy a healthy food basket with that kind of money for a family. It really is difficult. And for me, we have to bear those kind of context numbers in mind. So the biggest effect of this struggling economy is that it drives the social determinants of health. Now, this is a bottom-up thinking about what drives the health or the illness of your nation. Employment and income, being able to earn an income and afford food, afford a good food, a healthy food, being able to exercise is a privilege for most. A safe neighborhood and community access to clean water and sanitation, food I've mentioned, adequate housing, and then education. All of these things contribute meaningfully, much more than trying to shave a little bit of money off of a hospital negotiation, or a new medicine that will come in at a lower price and buy a little bit of extra life expectancy. For South Africa as a whole, the social determinants of health, if we could fix these, would give us much more bang for buck than the sort of curative approach to care once people get sick. Now, I made this point already, but just to hammer on it again, the health system operates within a context. Yes, if people are healthier, they're able to, may be able to work better, be more productive, etc. But we aren't able to absorb the workforce that's already there into the jobs that are available. So the health system on its own cannot be the fulcrum on which we try to fix the equity in the overall macroeconomy. It's always going to mirror the overall system. When we're thinking about the kind of things we have to fix, now we start getting into diagnosing the problems. I found this a very meaningful and useful report. Unsafe sex, given that our HIV prevalence is so high, this is still a massive driver of our burden of disease. Malnutrition is number 2, which speaks to the social determinants of health that I was talking about earlier. There's growth stunting. There are all manner of other things that come from malnutrition. Then we get into a high body mass index, high fasting glucose, high blood pressure. These are the behaviors, the metabolic outcomes of poor nutrition and poor exercise. Tobacco use and alcohol use, the sort of so-called bad habits. And these two together contribute dramatically to our burden of disease. There was a report that showed that smoking accounts for more than 8% of deaths in South Africa in some way. Alcohol use accounts for more than 60% of road deaths. Air pollution is something that sort of gets a side mention when we talk about climate change, but we don't really know the quality of the air that we're breathing. We pay some attention to the quality of the water that we're drinking, but we don't pay any attention to the quality of the air that we're breathing, and it has a significant effect on burden of disease. Dietary risks, and then unfortunately, again, not a list you want to be on as a country. Partner violence and gender-based violence in South Africa is a massive problem. Just to pick a couple of headings to look at, each of them require policy implementation, a lot of time and effort and resources to resolve. 3 to 5 are, as I say, the non-communicable disease markers. There we need to have massive drives around diet and exercise. Not just sort of fringe wellness programs that appeal to a particular audience. We need this at a systemic country level. How can we incentivize it? How can we lower the cost of healthy food? How can we disincentivize the junk food pandemic that is going to drive this non-communicable disease burden that we have going forward? Tobacco and alcohol use, the policy levers there we have seem not to be particularly effective, other than completely shutting down an industry where we saw people not being able to buy alcohol, which caused mass panic and rioting in some cases. But it did have a positive short-term effect on the health system. As soon as those are taken away, people again begin consuming alcohol on weekends, back to the old habits, and the effect on the health system is very evident and responds immediately. It's not practical to shut down these entire industries, and so we have to think of better ways to do that. We put taxes on top, but that punishes the consumer and promotes illicit trade. We need to think of other alternatives. For example, perhaps there should be higher corporate tax for companies that produce products in those industries. Dietary risks for us is, I think, a massive missed opportunity from a policy point of view. At the moment, public health policies think about salt content and sugar content, etc. But there's lots of studies on better ways to present information to people that make them understand. You want to have this burger? Well, that's equivalent calories to a 5-kilometer run, etc. And then people, if you can equip people with those kinds of that kind of education, that kind of information, they will hopefully make better decisions. Financing, because I work in the sector, I can't not talk about financing. And here we also have a lot of work to do. The policy plans for NHI are bold, but unfortunately we're persisting with the strategy of Big Bang. Up until 27, there was a very incremental, well laid out pathway for universal health coverage. And after 2007, we decided to do this Big Bang approach. Now, the problem is, instead of now being worried about us not finishing health reform, now we've been in a situation for the last 15 years where we haven't even started health reform. And it's a bit like trying to climb a ladder with 2 big steps. You're really going to fall a lot along the way and perhaps not even get there. So you need small incremental steps if you're going to have effective execution. We've got essentially 30 years of unfulfilled universal healthcare coverage reforms, and we all want that, and we all want greater equity in the system, but we can't agree the best way to get there. Similarly, we have 20 years of incomplete and ambling private sector financing regulation, which is, again, evident in the HMI documentation. The PMBs are supposed to be updated regularly. We're still fighting about insurance demarcation. There's no space in the Medical Schemes Act at the moment for innovative approaches to funding, thinking about wellness, thinking about incentives. How can you get people to engage in healthy behavior, exercise? The whole model is about paying for the cost of care once you're sick or once you're ill. And that model is not going to help us fix the burden of disease in South Africa. So I want to now just helicopter through each of the areas that I've touched on, the macroeconomics, the public sector and private sector, with some suggestions, just 4 for each, just to keep it manageable, otherwise the list gets too long. Firstly, we need to move to a situation where government is buying local. And not just a local representative importing goods produced in other countries. On a look-through basis, we need to boost our local economy. That includes in the medicine sector, by the way, in the health sector in general, but medicine in particular. The majority of HIV medicine used in South Africa is imported. It makes absolutely no sense when we have the manufacturing capability here. From a policy point of view, there should be incentives for corporate South Africa to do the same. From a job creation point of view, it's a bit of a hobby interest for me. The paradigm shift for me needs to move away from being a passive, enabling environment, policy regulatory environment, to being an active job creation space. And there are many models for that. I was inspired upon reading Muhammad Yunus's social entrepreneurship way of thinking, what they did with the Grameen company in Bangladesh. Really extraordinary stories, and there's no reason South Africa couldn't do the same. And then when we think about our demographic dividend, we missed our first demographic dividend, which is a wave of young people coming through with lots of energy to make something of themselves in the economy. We completely missed it, and now we have a lot, because of apartheid, and now we have a large unskilled workforce that are driving that large unemployment number that I mentioned. We need to find jobs for that portion of the population as soon as possible, meaningful jobs. We need to increase our expenditure on infrastructure and other areas to give jobs that match the skills we have in the country right now. But at the same time, to capitalize on our next demographic dividend, which is the youth coming through now, we need to give them skills so that they'll be able to fulfill the jobs of the future. And we need to do both of those at the same time. Otherwise, we're going to miss the boat completely. From a public sector point of view, lots of talk in some quadrants of the press about, well, just first do better with the money you have in the public sector, show that you can make use with that money, and then, you can have the argument to say, well, we can top up the health budget. And again, I like to remind people there what the health budget actually is per person. It's not a lot. About 4,500 Rand per person per year. It's about, the private sector is about 5 times that, 4.5 to 5 times that, although private sector comes in a wide range. You will find some medical aid options that are merely double that. And there are good reasons for that. We understand why there is that difference. But 375 Rand a month per person is not a lot to run the public health system. They do need more money. The question is where we find that money when we don't have the economy to prop it up. We're already in a precariously balanced welfare state. And so to find that extra money is going to be challenging. To manage that money better, we definitely need to appoint the right people. We need better management, and we need accountability. I stand corrected, but of the various health disasters we've had over the years, for example, the Life Esidimeni tragedy, there's no real accountability. People get moved around. and redeployed in other areas. But if I can contrast this one particular area with the private sector, that usually would not stand in a private sector kind of environment. A disaster of that magnitude, there would have certainly been dire consequences. And so there needs to be the right people, they need to be properly trained, and they need to be held accountable for whether they do a good or bad job. In general, there needs to be more education. I mean, it's not that HIV needs to be in every conversation, but we've become so complacent that we forget about just how heavy a burden of disease it is on our economy. 27% of people HIV positive. I'm not convinced that people understand the effect of what kind of food they're putting in their bodies. Our daily diets, they need to be educated. They need to be given alternatives. They need to be saying, okay, if you're buying this kind of grocery basket, then this would be a healthier alternative at the same kind of cost. We need to redouble our efforts on safe sex and other risky behaviors that drive HIV, which in turn drives the TB epidemiology. Just to give you a sense while I'm remembering now, I mean, call it 275,000 overall deaths due to COVID over a 2-year period. We lose, firstly, it's important to bear that number in context. About 450,000 South Africans die every year, about 1,300 a day. It's not a number that you would ordinarily think about in the course of your daily life. But when we were reporting on daily COVID deaths, that kind of number is important to bear in mind from a context point of view. But 125,000 a year are going to be HIV and TB. That's every year. And it's on an ongoing basis. We're not worrying about waves. We're not reporting every day about how many people are dying from HIV and TB, but that's the level of burden of disease we've become complacent with as a country. And then practical partnerships with NGOs, academic centers in the private sector. So we see lots of, and COVID was a good example of that, lots of hand-holding and studying data together, etc. And some examples of very effective partnerships and collaboration between private sector, but it also showed just how much work we have to do to make that a much smoother, slicker process. I remember very late nights talking about what it would cost if they needed to transfer a COVID patient from a public sector hospital to a private sector hospital, with Department of Health officials. There really were, if there was more time and planning, I suppose we could have done a better job. It showed that it's possible, and it showed that at need it can be done, but we need to be deliberate about it and plan for it as opposed to just react in an emergency. And then in the private sector, it's becoming more and more critical with each passing year that progressive regulatory reform is brought to fruition. We've really have not done anything meaningful in the last 20 years. PMBs have not been meaningfully updated since 2003. They need to be completed, they need to be flexible, they need to allow for innovation so that the private sector can do what it does best, which is innovate. We need to embrace this concept of value-based care, and I'm using the term very broadly for all stakeholders, both funders and providers. It aligns interest in the sector. We need to think much more carefully about strategic provision of care, strategic purchasing of care, and value-based care is a very useful framework to remind everybody what it is that we're trying to achieve in the system. Healthcare professionals need to be open to explore new models. We've heard about teamwork, which is mostly non-existent in the private sector. We need to do much more there. And then private sector training, which is one of the things that would be a 25-minute talk on its own, is really one solution to the human resources for health problem that we have. Again, there we have good policy. The policy document, HRH policy document, was updated 2 or 3 years ago. Unfortunately, if you look 10 years before that, it was almost the identical policy, and really nothing has changed from an implementation point of view. We seem unable to unlock skills development there, and there's really no need for that. We could harness private sector participation. And then we need to find a way to incorporate wellness, behavior improvement and incentives into the risk pool. It shouldn't only about insurance-based catastrophic protection so that you don't have high out-of-pocket expenses if you happen to go to hospital. We need to find a way to work with members, patients, align interests at that level to make sure that behaviors are improved so that we don't reap the whirlwind of this non-communicable burden of disease that's going to affect both sectors materially. And I'll leave it there, Leanne.
Barry, thank you. Thank you very, very much for that. I must say, I was snapping away at some of your slides and left gobsmacked at those particularly causes of deaths here in South Africa, and that is absolutely frightening. That yes, we've been ignoring these health issues for a very, very long time, and it's time to take those by the horns now and try and see what we can do. But Barry, amazing. Thank you very, very much. Again, remember, send in your questions. Barry will be joining us for a panel discussion afterwards, but his insights absolutely invaluable, and I hope you enjoyed that as much as I did. Taking notes down frantically, I have to tell you. Just a real reminder that there are so many other things that exist out there that we have been ignoring.